Well, ladies and gentlemen, I know it's a little early, 5 minutes early, but we're going to kick off anyway, which gives more time for questions afterwards and for an early lunch, and also means you may have more time to go around the exhibition, which definitely need the attendance. The Helen Rollason Lecture, and it's my privilege to be an honor to be able to introduce our speaker, Professor David Tuveson, for this lecture. Too often, pancreatic cancer presents late, as in the case of Helen Rollason, who presented to me in 1997 with advanced colon cancer with multiple liver metastases. And although we did the definitive surgery on her colon in the hope that Merv Rees in Basingstoke would be able to do something for her liver, it was so advanced that the only thing that she could have was chemotherapy. And I looked at her book again the other day, and in it she said, and they only gave me 3 months to live. She demonstrated a tenacity and a desire to use her skills as a TV sports commentator to remove the mystique of cancer. And she spent the 2 years that she had left promoting the cause of chemotherapy, palliative care, and surgery, and trying to make people aware that there was a way to beat cancer. Sadly, she herself did not survive, and in her autobiography, which she wrote, Life's Too Short, she demonstrated that fighting spirit that often patients need to survive and keep going. And we, all of us in our practice, try and give patients hope so that they can see themselves through the last years of their life. In a way, I feel that if we had had the benefit of translational research and gene therapy, etc., which some of the things that David is going to talk about today, that somebody like Helen might well have survived. Now, David Tuveson graduated from Johns Hopkins with an MD and PhD and did a fellowship and residency at Harvard Medical School and the Brigham and Women's Hospital in Boston. He was an associate professor at the University of Pennsylvania between 2002 and 2006, and for 6 years spent a period in Cambridge here in England as director of the Cambridge Pancreatic Cancer Centre at the University of Cambridge. So he knows about us Brits, so we can't put much past him. But in August last year, he had an offer he couldn't refuse, and he transferred back to New York to become director of research at the Lustgarten Foundation and leader of the Lustgarten Foundation Pancreatic Cancer Research Laboratory at Cold Springs Harbor Laboratory in New York. And that lab, by the way, was founded originally in 1890. It's an interesting establishment because it has a record of some 8 Nobel Prize winners, one of whom was Watson of Watson and Crick, who himself was from Cambridge. And if you remember this year, I think it was in February or March, we actually celebrated 60 years since the discovery of the DNA double helix. So David, no pressure there as far as that's concerned. The aim of his laboratory is threefold: to detect pancreatic cancer early, using those techniques to help patients, to identify new targets for drug development, and more effective approaches to deliver drugs directly to the pancreatic cancer. No doubt in this talk we will hear much, I hope we will, about Sleeping Beauty and the Mouse Hospital, and that will demonstrate to you just how down-to-earth David Tuveson is and how important it is to get a message out to the patients you're trying to treat. And so, ladies and gentlemen, it is with great pleasure that I call Professor David Tuveson to come to the podium and give us the Helen Rollason lecture today on developing better treatments for cancer. David, thank you.
Thank you very much, Lord Ribeiro. And thank you to Professor Primrose for this great honor to give this lecture, at the, which is earmarked after a beautiful lady who lost her life when she was very young and very full of productivity. So unfortunately, in pancreas cancer, the story we heard about Ms. Rollison is far too common. Many of our patients come to us with hope, but with such a devastating illness that, except for those of you in this room who are able to remove their cancer and cure a fraction of them, we don't have therapies that impact their lives meaningfully. And so today I will talk about how we approach this disease, pancreas cancer, and how we think about new approaches to detect the disease early, treat the disease when it's occurred, and potentially provide a framework for how we can design clinical trials that will lead to better outcomes for patients with this illness. Much of my work is done in collaboration with providers of therapies. The names of the firms are listed there. The audience needs very little introduction into the importance of the pancreas, which is a vital organ, allows us to digest food and balance blood sugar. For most of us, it does the job unfailingly. But for 1 out of 86 people who live to be approximately that age, pancreas cancer can develop. And approximately 250,000 people a year worldwide are diagnosed and die of this disease. Oftentimes, again, as I mentioned, the disease presents late, and most of them would not qualify for a primary resection of their tumor. We know a bit about this cancer. It's been studied fairly intensively for several decades now. So from the scientific and epidemiological standpoint, we realize now that tobacco products are probably the major risk factor for developing pancreas cancer. The new epidemic of being overweight and eating carbohydrate-rich foods in the Western world is another risk factor. Familial pancreatitis and other familial cancer syndromes are also risk factors for developing pancreas cancer. And so in the background of those risk factors, this disease does occur. But again, I've taken care of a good number of vegetarians who have none of those risk factors and get pancreas cancer. And so it's an increased risk, but it's not a clear causal association yet. Again, most of our patients, when they present, they're sick. And if they're sick, oftentimes they're referred to you, but you refer them back to myself. So I trained as an internist and as a medical oncologist. When I was a medical student at Hopkins, I actually thought I was going to be a surgeon because surgeons represent the reason why we have medicine, which is to cure the patient. And I had fond memories of being in the operating theater with John Cameron for many hours, talking about the anatomy of the mesocolon and various ways he was going to try to anastomose our patient. In the end, I decided to go the medical track as opposed to the surgical track, primarily because I thought I would have more time to think about the disease and work in the laboratory. And I think for me that was the right choice. But most of my colleagues who I talk to about curing the disease are such as yourselves, surgeons, because you want to fix the problem. And again, today I'll talk about how the medical oncology perspective possibly will provide more patients for you, so together we can try to fix this problem. Because in my neck of the woods, when the patients present sick with obstruction of their biliary tract or their small bowel, with a pain syndrome that I can't make go away unless I anesthetize the patient with opiates. Occasionally you can do a nerve block, but that doesn't work very well. With wasting of the muscles on their back and their heart, and with blood clots that come and go seeming whimsically throughout their body, it's hard to actually help these patients. And so because they're so ill, a lot of patients don't qualify for clinical trials, and they're given the meager chemotherapies that we have available today. And again, as I said before, surgery is the only curative treatment, and so if we could identify a bunch of patients early, potentially we could help many more of them. And so a simple cartoon of how we think of this disease is shown here. Again, the pancreas makes the enzymes that allow you to digest food in the acinar cells and produces the hormones which balance blood sugar in the islets. The cell that is the workhorse in the pancreas is the cell that lines the ducts, the tracks that the digestive enzymes flow down. And these cells protect the pancreas from digesting itself. And so these are simple cuboidal epithelial cells shown to the left. They're similar to the cells that you have lining various tubes in our body. They turn over very slowly. Their proliferative rate is about once a month, not like the intestinal mucosa, which is on the time span of days, or the acinar cells of the pancreas that make those enzymes, which turn over once a week. And so they essentially protect the pancreas and transport chloride and alkalinize the pancreatic juices. And they work well most all the time, but they can acquire mutations in genes such as Kirsten-Ras, which is in many respects the Darth Vader of pancreas cancer. This is the causal genetic mutation for which society has created no therapy. It's a small protein that's an enzyme that catalyzes the cleavage of GTP into GDP and orthophosphate. When it's mutated, it becomes a worse enzyme, meaning it moves very slowly. And so this very dull-witted protein somehow becomes the nidus for the construction of man's worst cancer. And again, we have no drugs that speed up enzymes. We have drugs that slow down enzymes. And so we need to think differently about this as a chemical and biochemical problem. So nonetheless, this mutation is likely the first event, and then multiple other mutations do occur, such that by the end, when you have a cancer that invades and spreads through the body, it oftentimes has 2, 3, 4 mutations, including tumor suppressor mutations that you've heard of, such as P53 or P16, which is in the RB pathway, or finally SMAD4, which was called originally DPC4, deleted in pancreas cancer 4. And these are 3 tumor suppressor genes that, again, play into the development of the disease. So armed with this information, which came from meticulous dissection of surgical specimens by geneticists and pathologists, including Ralph Ruban and colleagues listed here, we were able to create a model system some 15, 16 years ago in a little mouse in efforts to learn why is pancreas cancer so bad and can we do something about it. And today I'm just going to go through some of our thinking behind that and some of our findings and hopefully some of the forward directions that will be meaningful for you all. And so again, our approach was rather straightforward. There was a mouse that in the pancreas, we could actually turn on this KRAS gene, and we could turn on other genes, the mutations, for example, in the tumor suppressor genes I mentioned before. And if we only turn on the KRAS gene, we get these early neoplasms in the duct, where the ductal cells have mucin in them, not just cuboidal, simple cuboidal. And so you can see these. The acinar tissue looks fine. The islet looks fine. And so an early pancreas cancer is formed. Doesn't kill the mouse for some time, until about a year of age, when the mouse develops an invasive cancer. And then the mouse dies. And the cancer spreads through its body, looks, for all intents and purposes, like the human disease. In fact, if you send the slides to the human pathologist, they cannot tell the mouse from the human just by H&E stains and other approaches such as that. And so both of these models, the early model and the advanced model, can be useful for the clinical problems I talked about. The early model, obviously, for early detection and possibly prevention of the disease. The latter model for designing some proper therapies that make the cancer go away and the mouse to live longer. And so today I'll talk about both of those aspects. So early detection, the problem is, as stated, fairly simple. How do we find patients that have a late-grade early cancer, meaning an advanced intraepithelial neoplasm that hasn't spread through their body, hasn't invaded and metastasized? How can we do so? Cervical cancer used to be one of the main causes of death for women until the pap smear approach was developed. And that's which is a physical approach. Scrapings, look at it under the slide. Grades of cervical cancer were noted at that time, and for advanced cervical intraepithelial neoplasia, surgical procedures are performed. So how could we do this in the pancreas? We can't easily imagine ways to get scopes or little bristles and things of that nature to physically go up the ducts to the smaller ducts to assess things. You know, potentially we could get pancreatic juice, and approaches like this are on the way. But I suspect we're going to need a more clever approach where you can tell from outside the body whether a patient has a high-grade pannin. And I don't know if anatomic approaches will be good enough if we will get, you know, high-resolution thin-slice MR, for example, to work in this regard. The thinner the slice by MR, the more still the patient has to lie. You have to basically have a totally knocked-out patient to do that. And ultrasound has been okay, but not great, to see small abnormalities. So the approach that we've been taking has been one of, if we could find something that was a biomarker that you could identify, for example, in the blood or even in the intact organ, could you see very tiny abnormalities with that biomarker that would predict that there was a high-grade but non-invasive preneoplasm? And so our approach has been to look at a variety of proteins, lipids, metabolites, glycolipids, and glycoproteins, which may be signatures of that high-grade state. Now, many of you know that when a patient presents with pancreas cancer, one of the things that we measure in their blood is carbohydrate antigen 19-9. It's a marker that is oftentimes elevated, although not always, and if elevated, can be used by medical oncologists and surgeons to follow the course of illness in a patient. And this, in some ways, is like the PSA of pancreas cancer, but it's not quite as good. I realize PSA is a controversial topic. But CA19-9, again, is thematically what we're looking for, but a much better one that is much more sensitive, much more specific, and even very good, again, for the high-grade pannins. And so we were looking for things like that, and one of the proteins that we noticed is actually a protein that's present in normal intestinal epithelium called Claudin-4, which is a very important protein for the tight junction between two colonocytes. And this is a membrane spanning protein which has a exposed extracellular loop. There are multiple isoforms of the gene, meaning that there are splice forms. So if you look on a protein gel, you'll get many bands. And we looked at this because we found that this is a protein that was expressed first in the pannin 2 stage, which is, again, after RAS and then after one of the tumor suppressor mutations, such as P16. So this is using an antibody looking on tissue sections. Here's pannin 1, and this is pannin 2. And you see the brown stain. There's a bit of Claudin expressed. And here's pannin 3, lots of Claudin. And here's proper cancer surrounded by the oatmeal mush of the tumor. And there's lots of Claudin here, not in the stroma. And we'll talk about the oatmeal aspect of the tumor in a moment. So this looks, you know, like it's expressed at the right time, albeit also in the intestines and in other sites. And so we asked whether or not this expression was restricted to pancreas cancer and to late-grade pannins and wasn't present in chronic pancreatitis, which, as you know, is one of the differential diagnostic dilemmas occasionally for patients for which we don't get good biopsies of their lesion to diagnose them. And so importantly, chronic pancreatitis by this immunohistochemical score has a very low level expression of Claudin compared to cancer. And again, it's present also in these high-grade pannins. So we were emboldened that this might be an approach. And so we did various experiments in the laboratory, such as taking pancreas cancer cell lines and using an antibody to the protein to see that we could demonstrate this protein. It wasn't present in other types of cancers. And because there are 24 isoforms of Claudin, we knew an antibody approach might be hard. So instead, we turned to a bacteria that actually makes us sick because an enterotoxin from that bacteria binds Claudin-4 and actually causes the death of the colonocyte, resulting in diarrhea. And so Clostridium perfringens actually is the the bacteria that can do so. It produces an enterotoxin that, again, binds Claudin-4, leading to actual apoptosis of the cells, and finally the patient ends up with bout of diarrhea. It's clear which part of the protein binds to Claudin-4, and that's this part of this enterotoxin, whereas this is the bit that makes you sick. And so we could just use genetic engineering and use that tag from the bacteria protein to make a probe, to make a flashlight, to find this protein. And so we did so. We lopped off this bit and put on another bit, and that was what you see here for GST. It allowed us to purify it in the laboratory, put some labels on it, and look to see, would this thing bind to Claudin-4? Could we use it to see an early cancer in a mouse? And again, here's some simple experiments in the lab you can do. The probe can bind to cells that have Claudin-4, not to cells that don't have it. And if you mutate the probe, it will not bind. And so various controls are shown here. We used fluorescence reflectance imaging, which is something that you don't use clinically for much other than intraoperatively. It's an experimental approach for certain cancers. And it has been pushed as potentially a better way to find early colon cancer, where you can get very close to the piece of tissue that you're concerned about. So in a mouse, we were able to develop this as an approach, so as opposed to using radionuclides. And you can see again that the probe lights up. Red is hot, meaning more probe. The probe lights up the cancer in the mouse that has the pancreas cancer, not in the mouse that has the fibrosarcoma. And if you do various controls with the probe, it won't bind to that cancer. And so that was promising. But as you can see, when we take the organs out of the mouse, as I mentioned before, Claudin-4 is expressed in the intestines. That's how the bacterial toxin makes sick. It's also expressed in the liver, where this protein is present. And so when you take the liver out of a mouse that has fibrosarcoma or this transplanted pancreas cancer, the big red blob here is the liver. And in this case, the pancreas does not, the pancreas tumor that you have from this also lights up, but it's less intense than the liver. And so again, might work for early detection. You just have to know anatomically that you have to pay attention. And we can quantify such things. So that was interesting, suggested we could develop this as a probe, but of course we wanted to test it in the mouse model that got pannin, got the early pancreas cancer. You can't transplant pannin. You have to transplant a cancer cell that it has, properties that are more advanced than the intraepithelial neoplasm. And here's pannin in the mice. So you can see pannin in the mice have Claudin-4 as shown here, as do the cancers. This is using the antibody. And by Western blot, there's lots of Claudin-4 in the mouse pancreas cancer lines and a little bit in the pannin. And so then we applied the probe to these mice. And on the bottom is a normal mouse. The next mouse has early pancreas cancer, pannin, and the top one, proper invasive pancreas cancer. So we could put the probe in, get our images of the mice. In each case, we could see the liver as this big red blob. In the normal mouse, the pancreas is cold. In the mouse with pannin, you start to see the red spots. And when it has cancer, you see a bigger red spot. And when you take the organs out again, you see the big liver spot in number 1. But again, you don't see the normal pancreas, but you see pannin, that little red spot right here. And that was a pannin too. And when you go up, of course, you can see the pancreas cancer very easily. And so, we could also use this to find early mets in the liver. But again, as a proof of concept, suggests that this might work. Now, we couldn't give such a peptide to a human. It's quite likely that we would make an antibody response to it very rapidly. But now this is an approach that Albrecht Nisi, who's gone back to Marburg, and Thomas Grice's group, is trying to move forward on as a potential new way to see pancreas cancer early. So this was, I guess our prototype. We now have, some very exciting approaches to see much more deeply and much more broadly. And the CA19-9 biomarker I talked about before, we actually now can make CA19-9 in a mouse, which is not possible unless you intervene genetically, because Lewis antigens A and B are not made by mice. And so we've engineered that in, and now we can actually see CA19-9 in an early mouse pancreas cancer, and we can use that as our hook to pull out a plethora of interesting biomarkers. And so I'm actually quite optimistic about this. And if we can sort this bit out, then obviously instead of you all getting 10 to 15% of the patients, maybe you'll get 50%. So you might not have the time to be a liver transplant surgeon and a pancreas cancer surgeon, which is, again, a good problem to think about, because that would be, you're going towards the goal of actually curing patients of the disease. And so that's our first effort in diagnostics. The other effort is in taking care of the patients that we are referred. Now, pancreas cancer therapies have a long and storied, dismal history. And it's not for the lack of trying. It's not for the lack of talking about it, thinking about it. But we've been, terribly ineffective. And so when I was training as an internist, colon cancer was not quite as bad as pancreas cancer, but it was pretty close. When you had metastatic colon cancer, as the namesake of this lecture passed away from, that was equally bad. And nobody was resecting liver mets then. Of course, everything changed because better medicines came online, not so much targeted agents as better chemotherapy. And again, the fate of a colon cancer patient is radically improved in the last 20 years. That has not happened in pancreas cancer. But we have, a few leads that we're excited about. But again, I would say our foray into pancreas cancer was not jumping in to make the RAS drug, because we're not chemists per se, although we, I guess are forced to now think like chemists. And we imagined that the best and brightest would be making that RAS therapy. We wanted to understand first, why was it that the drugs that worked in tissue culture failed in our clinic? And by understanding failure, perhaps we could do better. So the approach we took, again, was to take the furry mice and to do a very unsophisticated approach of feeling the tumor in the belly of the mouse to enroll them. So it becomes an issue of numbers. When you are trying to study cancer in a model organism, you need a simple way of assessing disease presence, disease progression. And it turned out we didn't need a fancy machine for that, but actually you just needed your forefinger and your thumb. And I didn't believe it, but the staff in my lab who were very skilled were able to do so. And so you could actually just screen through lots of mice, several dozen, before tea break. And if you feel something, you go back and feel it again to make sure it's not fecal contents. And if it's still there, and it's tiny enough, meaning BB-sized or only a few millimeters in diameter, then the mouse gets a proper ultrasound to see the tumor. And that actually is sufficient to anatomically see the tumor. So step one, if you're positive. Step two, this is a mouse swimming in jelly, probably more than it needs. And this is the machine that you can use very simply to get a high-resolution volumetric assessment of the tumor. And this is important because we would assess and enroll mice based on the size of the tumor and how rapidly it was growing. And so each mouse was an individual patient. And it was randomized to different treatments, and then we would see where the chips fell. And the basic observation from the first 3 years of this project is summarized here. If mice have a tumor in their pancreas and we treat them with a variety of drugs, they're generally very resistant. And if we take the tumor out and put it under the skin or chop it into bits and put it back in another mouse's pancreas, we find that now they're sensitive, which was very puzzling. And so this observation led to a series of experiments where we tried to understand that. Because in essence, you're saying it's not the cancer cell responding, it's something else about the structure of the tumor, which must be playing a role. Because whenever you remove a tumor and put it back somewhere else, some other site, you have altered the microenvironment. And as I mentioned before, when I speak to the lay audience, which you are not, I describe pancreas cancer as an oatmeal cookie, which I don't know how popular they are in Britain. They're very popular in the States. And so the raisins are the cancer cells, the oatmeal is the stroma. And that hard rock white stroma is what you're used to seeing when you resect a pancreas tumor. It's not a breast tumor. It's not a colon tumor. It's not soft and bloody. It's actually hard and white. And so we studied the hard white stuff a variety of different ways. And it turns out that's an important component of the tumor to explain, I think, a lot of the therapeutic resistance, but potentially it opens the door for developing proper therapies. And so the experiment that I described is shown here. If the mice have transplanted tumors, These are pairs, 5 pairs of animals that have either human pancreas cells into a mouse or mouse pancreas cells into a mouse. In blue, everything grows over a 12-day time period. Here's 0. This would be a doubling, 200% increase. In red, nothing grows if you give the therapy, which we've used most of the time, which is gemcitabine, a monotherapy nucleoside analog, which many patients with pancreas cancer are administered. So gemcitabine looks like it works compared to salt water, but when you look at the tumor which occurs and arises in the pancreas of a mouse, salt water, they double. Gemcitabine, they double. No difference. And so that was a stunning result, and we looked at it in a variety of ways. I'm going to focus your attention first on these numbers here. We could measure gemcitabine. This is the drug we give. We could measure gemcitabine triphosphate. That's the actual poison that gemcitabine is turned into, using pharmacological methods. And by doing so, we could show that the poison we were looking for was not in this tumor, but it was in that tumor. And again, this is a tumor that arises in the pancreas. You see all the white swirls? That's that oatmeal, the stroma of the pancreas tumor, the hard, rock-hard white substance. And the pink bits are the cancer cells. And here's normal pancreas, here's a bit of small bowel. So the gemcitabine was not getting into this one, but was getting into that one, because we did a different probe, and you can't see it so well here under the bright lights, but this is green. This material that's green is actually adriamycin, the breast cancer drug that you can use as a probe when you do a vascular study. And it gets in here, but not there. But it gets into this tumor just fine. So we had an issue about things getting into the tumor, and we sought to understand that. And we used fancier imaging approaches, and this is an ultrasound on the left, where lots of bubbles get into the transplanted tumor, but not into the primary tumor. And then by MRI, you can't tell the 2 tumor types apart, but if you infuse gadolinium, DTPA, which has a molecular weight that's small in the 500 range, we use this for dynamic contrast enhanced MRI in the clinic. The GAD doesn't get into the tumor. It piles up on the outside. The big black hole in the middle is the living tumor that's not perfused well compared to that tumor. Now, these observations have now been repeated in actual patients, and it seems to all look the same, even by CT with contrast thin slice. These are observations that have been made for years, but not thought of. And so, because when we slice the tumor, fix the tumor, look at it under the microscope, looking at normal acinar tissue or the tumor itself up close, and in this case, trying to detect blood vessels where there are these brown structures here in normal acinar tissue. There are very few brown structures in the scar, just like there are few blood vessels in a scar anywhere on your body. And so pancreas cancer actually is a scar with cancer cells and very few blood vessels. And we could count those blood vessels, and there are very few inside the tumor compared to outside in a mouse and in a human. And in the mouse anyway, we could ask how many of the blood vessels that are present actually function by, again, infusing proteins that would bind to blood vessels if the vessel was open. And in that case, only a third are open. And so pancreas tumors have 10% of active blood flow compared to normal tissue. They're anti-angiogenic. They're hypovascular. And so we propose that maybe this is a block to delivering drugs and therefore to getting responses. And we searched for a variety of methods to fix this. And the first one that came to us was to strip the stroma out by using an inhibitor of the hedgehog signaling pathway, as shown here. We give funny names to a lot of the developmental pathways in our body because the creative fruit fly biologists who get there first get to name them. And so this is where one of these comes from. So the same creature that, that scurry around in the UK that are protected that I never did see when I walked out in the wild is the hedgehog. And when you have mutations in the hedgehog pathway, sometimes they can look like a hedgehog, sometimes they can look like a cyclops, one eye in the middle of the midline. Because it turns out that this pathway is important for endoderm-mesoderm interactions. And the red cells here are the cells that respond to the hedgehog signal. The green cells make the hedgehog signal. The green cells in this case are the pancreas cancer cells. The red cells in this case are the stromal fibroblasts, also called stellate cells in pancreas tumors. Turns out when you use a hedgehog inhibitor, the stroma goes away. And when the stroma goes away, the blood vessels come back. And when they come back, you can deliver drugs. And that's what that we'll show you here. So the stroma goes away when you use a hedgehog inhibitor, and the number of blood vessels come back. And now you can deliver drugs, and actually the pancreas cancer cells start to die. And when this happens, the mice live a few weeks longer. So these various colors to the left are the mice treated with saltwater or monotherapy with either chemotherapy or the hedgehog inhibitor. You mix everything together in a cocktail, and the mice live a few weeks longer. They don't live forever. They're not cured. They actually all die in the end. Because what we found was the stroma, which goes away, comes back. And the blood vessels which came back go away. And so it was a temporary balance that we knew we had gotten our foot in the door, but the door was being shut on it. And we think that's because the hedgehog pathway is also important for those new blood vessels to stay alive and stay viable. And, we were excited about the scientific bit of it, but we were very, I think, careful about how to clinically develop this. And this is where the breakdown between science and the clinic happened, despite our best intentions. Because we were certain that we could not move forward unless we could prove what was happening in the mouse was occurring in our patients. And so we turned back to the clinic. When I was in England, which I had, I appreciated terrifically, and was, am very grateful for the opportunity that I had here. I was, intent on practicing as a physician, and so I went through the process, and eventually was brought onto the professional societies, onto the General Medical Council, the Royal Society, etc. So I was ready to do a clinical trial, and we wanted to look at the biopsies that we call positive for our patients, and this is one such biopsy. So this is a cytology biopsy from a needle aspirate from endoscopic ultrasound of a patient that had a mass in their pancreas. And these are red cells and some white cells. And here are the unusual-looking cells with large nuclei and this other insoluble material, which is likely a bit of stroma. And so this might be fine for the cytologist to say in the setting of a mass and the rest of the clinical scenario, this is likely pancreas cancer, but it's really hard to think about a scientific approach using such a biopsy. And so with the physicians, the surgeons, radiologists, and pathologists at Addenbrooke's, we actually used the same needle biopsy. Instead of making a smear on a glass slide, we were able to fix the biopsy immediately in formalin and make these microcores, which are approximately the size of a hair, and very carefully put it out and pull it out of the formalin, embed it in paraffin, and cut it. And this is what they look like. And so this is a microcore. And here's the cancer cells surrounded by stroma. And so this was an experiment that we didn't have to have ethical approval for or anything, because the patient was cared for in the same way. One needle biopsy went for a smear, one went for this idea that we could make a better biopsy. And this was a project led by Nick Carroll, who's our very talented radiologist who does our endoscopists at Addenbrooke's, and supported by Raj Prasidam and Neville and Emmanuel and Asif, folks that you know well. And so this was something that we worked on for several years because we wanted a biopsy assay that we could use to follow patients on trials. And these biopsies are actually quite beautiful. So here's another example of an H&E biopsy. You can stain it for markers that tell you about epithelial cells, tell you about signaling pathways of various types. They're fabulous. And I'm hopeful that some of you will adopt such an approach, because this is what we're going to need for clinical trials for pancreas cancer, be it in the pre-surgical space or in the advanced setting. So as I told you, we were nervous about our scientific findings and how they would be rolled out. Now, the company we were able to get the cyclopamine derivative from, IPI 96 in Boston, they didn't have the financial bandwidth to try to do anything over here. And so they started a trial in the States, which is a phase 1/2A trial, making sure the molecule wasn't unsafe and looking for a dose that maybe they could go forward with. In the first 16 patients treated, things look great. So academic medical center, stage 4 pancreas cancer, metastatic. Patients went on trials. They had a median survival of approximately 10 months. They had a few patients with amazing responses. And so they went right into a randomized phase 2 trial, again with no biopsies. And then that was looking promising, because when they unblinded it, they had two categories of patients, patients doing great and patients doing less great. Turned out the patients doing less great were treated with these medicines. They weren't the control arm. And now it's a bit of a conundrum because there were no biopsies. And now they want my help. And so my message to them is my message to you, which is if some curious trainee, be it a surgical or a medical, comes to you with some clinical trial you want to do in pancreas cancer, refuse unless there are biopsies. And actually in the UK and Ireland, you can do these trials more easily because you can organize your healthcare system to support these biopsies. So Ben Stanger at Penn had an interesting paper about pancreas cancer maybe a year and a half ago. Some of you perhaps have read it. He did a genetic experiment where he deleted sonic hedgehog ligand in the cancer cells, thinking that he would have a genetic mimic of the therapeutic experiment I told you about. He in fact shows that when you delete the ligand, you get an undifferentiated cancer that lacks stroma, have a ton of blood vessels, and that by itself spreads rapidly through the mouse, suggesting that maybe there's a tumor suppressor role for this pathway, which no one would have predicted ahead of time. Now, this tumor probably is very responsive to chemotherapy because there's lots of blood vessels, et cetera. So it wouldn't explain necessarily the clinical failure, but I think does give us the time that we should pause and think about that moving forward. So it turned out that the hedgehog was not the only approach that we thought about for physical delivery alterations in pancreas cancer. The other one, which we developed, was to actually digest some of that oatmeal with an enzyme that our nurses use in the chemotherapy room today. So hyaluronic acid, called mostly hyaluronin now in the literature, is a repeating disaccharide that makes us pretty. It's actually what gives you form under your skin. So the dermatologists and the plastic surgeons probably are spending too much time on collagen and not enough time on hyaluronin. Hyaluronin is what actually gives water content to our skin, gives to our articular joints. It's a requisite macromolecule that looks like a bristle brush from long distance under electron microscopy. So again, it's a repeating disaccharide, has linker proteins, etc. It absorbs water. It makes a gel wherever it exists. Turns out hyaluronin is an extremely abundant macromolecule in pancreas cancer, probably 10% of the content. And as I said, our nurses use an enzyme that digests hyaluronin in the chemotherapy room, and that's only if a patient getting chemotherapy that's a vesicant has their IV dislodged such that chemo leaks under the skin, which can be a catastrophe. So the nurses inject hyaluronidase right next to the site where the IV gets dislodged, apply heat. The patient's arm becomes extremely wrinkled. The skin essentially, the surface area of the skin increases dramatically as the wrinkles form. And the idea is the lymphatics are allowed to pop open so the chemotherapy can drain out, et cetera. And so it's used already clinically. And so a company on the west coast of the States in San Diego has increased the half-life of hyaluronidase by pegylating it, putting some chemical molecules on it, and polymerizing it a bit. And so we were able to get this enzyme and ask what would happen in the mouse model that I showed you. So first off, again, this brown stain depicts hyaluronin in the stroma of our pancreas cancer. Here's a normal pancreas, and there's a bit of hyaluronin around the normal ducts, as there is under the skin, as there is in the articular surfaces, etc. But you can make this brown material go away within 1 hour, 8 hours of giving this enzyme by tail vein injection in a mouse. Mouse is fine. And by giving it by anticubital injection in a patient, we can do this too. Patient has pain. They have pain in their muscles, so we give them a bit of analgesia ahead of time, but they do fine too. So what happens when we do it? Well, when we do so, those blood vessels that are few in number and compressed, 2/3 of them are compressed, pop open. They pop open like a balloon. So they go from a flat tire to an inflated one. And when they pop open, now things work. The flow works. You can deliver things into them. So that's great. You can deliver anything. I would say equally important, when they pop open, they've had an architectural alteration. And I'll show you what I mean by that. So here's a little cartoon. You'll see a little better on the next slide. Therapies don't get into pancreas tumors because the blood vessels are compressed. But when you give this medicine, this enzyme, the vessel on the inside by electron microscopy becomes full of fenestrae or holes, permeabilized. Now these fenestrae, we've seen them before in the past. We think that's how VEGF works. VEGF was called vascular permeability factor. It's supposed to cause leaky blood vessels in cancers due to the elegant work of Napoleon Ferraro, as well as Doug Hanahan, Uta Folkman, Rakesh Jain. But it turns out in pancreas cancers of a mouse and of humans, because we've looked now in patient-derived pancreas tumors, the vessels are slammed shut. The endothelial cells are tight, and there are very few fenestrae in them. Here's just one or two examples, but look how many you get when you use this enzyme. The relevance of this is that when you have large therapies, antibodies, nucleic acids, gene therapies you heard about before, you can now get them in. And so this is a 2 megadalton dextran. It has a Stokes radius as big as this room. You can deliver it into the pancreas tumor stroma. See this yellow material, which is getting in by the bucket loads now. And so this is something that we are translating rapidly in the pre-surgical space by a trial that's been written, and it will be conducted at Memorial. So, by movie form, again, on the left, we have a condition where the therapy doesn't get in, but on the right, we can give this enzyme, and enough of the enzyme gets in to start cutting, and you get rid of the stroma. So now when you give your therapy, it actually gets in. And when the therapy gets in, it kills the cells, and the cells keep dying, and that's ultimately very helpful to the mice. And we hope for the patients. Now, in the small clinical study that's being conducted by a colleague of mine, Sunil Hingorani, who's located at the Fred Hutch, which is in Seattle, the first cache of patients have been doing great. And he's going to talk about that at the oncology meeting, the ASCO meeting, in a couple of weeks. And so they're looking to a randomized study now. Now, I'm after him to get those biopsies, as you heard me on my soapbox about that before. And, he's running into the same problem. In the States, we're just like we're too fast, and we're not, thinking as we move. So I'm concerned about the lack of biopsies, but we're trying to write a trial to pay for the darn biopsies so they get done properly, in addition to the imaging. And so again, I've told you two things about, or two ways that we can get around, hopefully, this physical blockade to therapy delivery in pancreas cancer. One is using a hedgehog inhibitor, which currently no one is using because of the failed randomized trial, I think with a conclusion to be determined. And the second is using an enzyme that would digest the oatmeal present in the tumor, digest hyaluronan, vessels pop open, deliver more therapy. Now, when we did these experiments, are we sure that we were only delivering the male better? Or could we be altering also the comforting nature of the stroma? The cancer cells are sleeping and living in this stroma. Is the stroma providing survival cues also for the cancer? And I'm going to tell you, but the last vignette is about an approach we've used to actually dissect that out. And that's to go after a protein that's been a very mysterious one called connective tissue growth factor. It's a protein which has befuddled many of us for some time. So this is a protein that has 4 domains. Each domain has a different function. It can bind to ligands, it can bind to receptors. It's synthesized and secreted by the stromal fibroblasts, which again, as I said before, we call pancreas stellate cells in the pancreas. It's made to a low degree by the actual neoplastic cells. Some of the ligands it binds are noteworthy ones in cancer biology, including the insulin-like growth factors 1 and 2. These polypeptides likely do play a role in most cancers. They can signal through their own receptor or through the insulin receptor by heterodimerizing. This protein also binds to integrins, which are well-known proteins that mediate attachment of other cell types, that mediate, again, cell-cell contact, as well as forces between cells and the extracellular matrix. Binds transforming growth factor beta, which mediates fibrosis in pancreas cancer and in tissue repair and in multiple other sites. And it binds to Wnt ligands. Wnt is another developmental pathway, very important in pancreas cancer and other cancer evolution. And so each domain binds something else. The protein is only 37 kilodaltons, so you couldn't imagine that it does all these things at once, since most of the things it's binding are larger than the protein. But it has this ability, this uncanny ability of doing all of these things. And one model of pulmonary fibrosis, which is very important in certain medical fields, is totally blocked by depleting CTGF in that setting. So if you give bleomycin to a rodent, you can cause pulmonary scarring. But if you give an antibody to CTGF, you prevent that. You ameliorate that whole event, suggesting, again, this is a very important protein. And so we looked at this as maybe a way to go after the stroma without dissolving it and without necessarily, purposefully altering the vasculature, and drug delivery. And so we looked first in the animals, and then we looked in patients. And again, the brown staining here you're seeing is actually the presence of the protein, CTGF protein, in the stroma of a pancreas tumor. And on the right is the way we've quantified various things. And so by ELISA, the CTGF levels are very high in the tumor compared to control mice that are healthy, and very high in the plasma in mice that are sick with pancreas cancer compared to control. So it seems like the protein is there. And as I said before, we can get fibroblasts from the pancreas tumor. They have high-level expression of this protein, whereas the cancer cells themselves very low. And so we had our target. It looked like it was present, so we could go to work. And the way we went to work is we used a therapeutic antibody. Now, therapeutic antibodies have been very useful for certain cancer types, mostly lymphoma and breast cancer. And so in lymphoma, there's an antibody, rituximab, which can treat patients who would otherwise be dying of a certain kind of lymphoma. And there are multiple other antibodies that in the blood cancers have shown extreme merit. In the solid tumors, there's an antibody that you've all heard of called Herceptin, which is an overpriced antibody that binds to ERB-B2, and it has been very useful for certain women with breast cancer that express the protein, ERB-B2 protein. Now, in pancreas cancer, we've done lots of clinical trials with antibodies, and none of them have ever been positive. And it's possible they've all failed, not because the idea was wrong, but because the antibody never got delivered to the pancreas cancer, as you heard me talk about already today. So we thought we were in a unique position in that we understood the biophysical issues of delivering big things, and yet we now have a target that possibly we could use a biologic against. So we have this protein, and we were able to obtain from FibroGen, a biotech based out of the Bay Area in California, an antibody which was humanized that could recognize human and mouse connective tissue growth factor. And we also got other antibodies so we could measure what was going on when we treated. And so that was our experimental design. Our approach was, as you've heard before, we could enroll animals, treat them with various controls or monotherapies, or give them, again, an antibody plus some other things to get the antibody delivered, and chemotherapy. And that's the red line. And so actually delivering the antibody with chemotherapy, we were able to get cessation of pancreas cancer growth over a week. It didn't shrink away to nothing, but it was actually very stable disease for that week. So we went on to analyze what was going on. We looked again at the stroma using chemical dyes, using antibodies to look at the presence of the stellate cells. And we tried to measure everything we could, and we didn't see that. It seemed to think that the stroma itself was changing by every parameter that we looked at. But what was changing were the tumor cells. The tumor cells were starting to die. And, as an oncologist, I'm trying to kill cancer cells. How I do it, I don't really care, as long as they all die. That's the chemical way of getting rid of the cancer that I would like you all to cut out. So we're doing molecular surgery. And so these yellow cells down here are the dying cancer cells. And these were the only types of cells that we saw dying during these treatments. We then asked about drug delivery because we had developed with Duncan Jodrell the best way of measuring the chemotherapy gemcitabine, and we saw no change. So we finally had a therapy that killed cancer cells, did not change the delivery of gemcitabine into the tumor. And we could look in the tumors for what was going on, and in the tumor, the target is this protein here, which is present. And when we give that antibody, we can cut this protein into different pieces. We didn't do it with the antibody, but we likely exposed the protein so that enzymes that were present endogenously in the cancer stroma just barbered it in half. Now, the function of this fragment of the protein, we have absolutely no idea. If it has function, if it works as a dominant negative, that is to confuse the way the normal one would work, or if it had new properties, for example. We don't know. But it's the first time it's been seen clearly in any therapeutic assessment to date. We're trying to understand that by identifying it and performing mass spectroscopy, et cetera. So the animals that were treated had cleavage of the target, and the animals were pretty well. They had a lot less ascites and metastases compared to the others. The mice looked well. And the mice lived, this time, longer than the other therapies that we've used. In the end, they died, but they didn't die of pancreas cancer. They died with pancreas cancer. Mice look fine, eating on the day of death, running around, grooming themselves. You can't talk to mice, but you can watch them. And there are certain signs when they're not doing so well. All the other therapies, the mice look sick, and they lose. And this time, the mice look pretty well. Now, it turned out when we opened them up, we saw a few blood clots, and as you know, Trousseau syndrome was named after him, and he had a GI malignancy, apparently. And you know, it's likely that these mice that are now healthy because of the therapy are again starting to show other manifestations of disease, which is fascinating, but wasn't the purpose of doing the trial. And so we think we have a different foot in the door now about this, and we've looked for the mechanisms of what might be going on, and it appears that this protein actually is stimulating survival pathways in the cancer cell. Survival pathways that regulate apoptosis of cancer cells. The biochemical mechanism that is at work, we still don't know, and this is where actually in vivo is harder to understand the molecular intricacies. That's where you need tissue models to move forward, and we now have a tissue model for this that looks very promising. But the conclusion, though, for this last vignette is that the stroma itself, besides posing this physical barrier, also provides survival cues to the pancreas cancer cells. And that inhibiting this protein may be a strategy to circumvent the resistance of pancreas cancer to therapies. And so, in summary, for the therapeutic side of things, I think we need to both get more drugs in and push the cells around so that they respond to the drugs we're providing to them. And this is, our perspective, on the problem now, that there are both types of problems operant. And probably collectively, this is the problem that we have with patients as we try to deliver stronger, more potent chemotherapeutics. We have to disable these, survival mechanisms. So when I was in England, the term that was given to the approach that we developed was a mouse hospital. And I never really used the term because I just thought of what we were doing with animals was really just the preclinical extension of what we were trying to do with our patients. But be that as it may, the people who did all of the work, who did the seminal work I talked about today, include Ken Olive, who developed the Cambridge Mouse Hospital, now runs his own laboratory in Columbia University in Manhattan. Mike Jakobitz, who developed the hyaluronidase approach. Chris Fries and Albrecht, who developed an approach I didn't talk about using nab-paclitaxel, that expensive taxane, which does show promise in pancreas cancer. And then Albrecht again for developing the detection method that I talked about early on. The work that I did in England was supported very generously by Cancer Research UK, as well as the NIHR, who, through the Biomedical Research Center, where we got the money to buy a portable ultrasound so we could do those biopsies that I showed you about for patients, because we're not for profit, our hospitals, and so we can't easily get our research agenda off the ground. But we were able to get it off the ground with far less resource than I have to throw at the problem across the water. And we also received support from the Lustgarten Foundation, for whom I now serve as Director of Research. So when Professor Primrose asked me to give this talk, I thought about telling him that it's too early for me to talk to you all, because I don't think we yet have an algorithm where I would say you shouldn't operate on a patient unless they go on a clinical trial, which is the algorithm I've been trying to develop, obviously, for the last 5 or 10 years. I believe in that, and that's what I'm trying to push at Memorial right now. And, at Memorial, they operate on 300 patients a year. They do 300 Whipples a year, and then if you add on the cystic cancers they take out, it's more. But we have our first trial that they've now agreed to do, 10 patients. Hyaluronidase, it's plus or minus hyaluronidase. All patients get cetuximab, which binds the epidermal growth factor receptor. And so we'll measure the epidermal growth factor receptor antibodies in the 5 patients that get hyaluronidase and compare it to the 5 who don't, to ask, can you alter drug delivery in a pancreas tumor in a patient who's going to get a resection next week or not? And they'll get paired imaging modalities also by DCE MRI to ask, are you altering it at that level in a non-invasive way? My hope is that these patients, if that works, that then of course we can mix hyaluronidase with some active compounds and start doing real experiments. That will be experiments, to be honest, but they'll be ones aimed at increasing the efficacy of our approach to our patients, so that first we have to make sure that it's safe and not more patients have pancreas leak, not more patients have perioperative mortality. But once that has happened, I'm hopeful that all the patients that you operate on will go on a clinical trial first, and that your trainees, you will allow them to be involved in such studies. It'll only take 1 or 2 years probably for them to do an attachment, with a laboratory to get such things going. And that in the adjuvant space, where we have a big impact with chemotherapy, we have better therapies, such as some of the ones I talked about. So again, my dream moving forward is that all patients with pancreas cancer have a chance at going on a clinical trial. The ones who are well enough to go on a clinical trial, these are the ones you operate on. The ones who are not as well are the ones you're not operating on. So I have to make them better so that you can operate on them. But the ones you're operating on, please consider neoadjuvant window studies first, and then efficacy studies once it's shown to be safe. So that's the reason why I accepted to come, because I thought in the end, even though I'm dissatisfied with the progress we're making, at least I can use the miniature soapbox to ask that you join in trying to change our approach to these patients. Same would be true in colon cancer, who now get chemo, resection, et cetera, of their liver mets. They should all go on clinical trials, all those people. But in any case, I want to thank Lord Ribeiro and Professor Primrose and the members of the Surgical Society of Great Britain and Ireland for inviting me here. It's been great. And like I said, with you, we will make a big difference. So thanks.